Hi, my name is Kristen Henderson, and today I'm going to talk to you about modeling fracture risk in women with osteoporosis. The goal of the project is to understand the risk of bone fractures for women with osteoporosis. There are two objectives. The first are to determine what factors are most important in determining the probability of a fracture, and how do those factors affect an individual's odds of fracture. And the second are how do different modeling approaches compare in terms of their prediction performance. Um, for the approach, first, I conducted an exploratory data analysis, then an interpretation of factors using logistic regression, and then building and comparing models for prediction, including a logistic regression, a discriminant analysis, and non-parametric models. Let me take you through the data set. So the data set is 500 observations, all representing each individual patients. The response variable is fracture. Did a fracture occur within the first year? And this is a categorical yes or no. The predictor variable types, there are 5 that are numeric. There are 10 categorical. And then there are 3 identifying variables, patient ID, study site, and physician ID. There's no missing data in the data set. I'll tell you a little bit more about the predictor variable groups. So many of the categorical variables are medical history and lifestyle type of variables, the prior history of fracture. Did your mother have a fracture? Was there an early onset of menopause? Things like this. Then there are physical and biological factors, which are numerical. Age, weight, height, and BMI, which is a composite variable of weight and height. Then medical assessment and medication. So did you take medication at enrollment, at follow-up, or both? Yes or no. And then there's a fracture risk score, which is a composite score. And this is numerical. And then there's some, as I told you, some metadata identifying variables. First, let me take you through the exploratory data analysis. So here are the summary statistics. In blue, these are the numerical variables. You can see that the age range of women in the study, they're postmenopausal women from 55 to 90 years old. In red or in orange is the fracture. So 1 in 4 women, this is the response variable, and 1 in 4 women experienced fractures, so 25% prevalence. In green, these are the categorical variables: prior fracture, maternal hip fracture, early menopause, are you a smoker, arms assist, self-reported risk, and medication at different times. And then these identifying variables, site ID and physician ID. So this is a scatter plot matrix, and what I want to draw your attention to are the density curves along the diagonal, and specifically 2 of them, age and FRAC score. And what I want to point out here is that these 2 variables are essentially the only variables in this set that you can see some good separation between the classes of fracture with women who had a fracture in red and those that did not in blue. And you can also see this in the box plots on the right. So most of the variables, the red and blue boxes, are lined up, but if you look at age and FRAC score, there's some differences in the distribution there. This is a correlation matrix that shows the correlation and the relationship, potential multicollinearity between some of these variables. And I'll draw your attention to age and FRAC score. So these are highly correlated. And also weight and BMI are highly correlated, which is not surprising, as BMI is made up of weight and height. So next, I'll take you through some of the numerical variables and trends that I saw. This is the proportion of women with fracture related to the FRAC score. And as the fracture score increases, so does the proportion of women with fracture. You can see that here where women who had a fracture are represented in red, and those who didn't are in blue. And the distribution of those in red is higher, have higher FRAC scores than those in blue. And here, this is just, again, to illustrate that age and FRAC score are linearly related. And as age increases, so does FRAC score. So there's some potential multicollinearity here. This is a contrast to the positive trend we saw in the last slide. So this is the proportion of fracture with weight. And you can see that the relative proportion of fracture does not change as weight increases. It looks like a relatively flat trend. You can see that in the box plots here where the categories of fracture have similar distributions. And this is just to point out the multicollinearity between weight and BMI, that these two variables trend positively with one another. Next, I'll talk you through some of the categorical variables. So in orange are the yeses, and in green are the nos. And so this is, on the left, is the proportion with fracture of women who had a prior fracture. And so unsurprisingly, the proportion of women with a prior fracture who have fracture within a year is higher. And again, that's the case on the right with women with a maternal history of fracture. This is similar, but for the bone medication variables. So women who need bone medications have a higher proportion with fracture. And then I just want to draw your attention to some interesting, potentially interesting trends. So this is looking at both women who took medication at enrollment and follow-up. And if you look at the green bar on the far left, this is women who didn't take any medication, and they have the lowest proportion of fractures. Now, if you look at the orange bar on the far right, this is women who took bone medication at enrollment and also at follow-up. And so this would suggest these have a moderate risk of fracture, or a moderate proportion with fracture. And this would suggest that potentially consistent use of medication is associated with a moderate or slightly reduced risk than not taking medications consistently. And that those categories are in the center. So either women who only took medication at enrollment but not follow-up, and vice versa. Those are the highest bars with the highest proportion of fractures. So here, this is to contrast two categorical variables that you didn't see a strong trend with the proportion of fracture between the categories. So it didn't seem to matter what relative age of onset of menopause was, nor did it seem to make much difference whether you're a smoker or not. And I will point out that there were very few smokers in this study. So I'll take you through the data processing. All of the data was used to plot the graphs that you just saw. But prior to fitting any models, a 70-30 train test split was created, and the models were built on the training data, but were assessed on the validation, the held out validation set. The identification variables, patient ID, study site, and physician ID, were not used for model fitting. Weight and height were both used in the analysis, but BMI was excluded because it's an interaction of weight and height and was highly correlated with weight. Bone med and bone med FU, which are medications at enrollment and at follow-up, were used, but bone treat was excluded as an interaction of the other medication variables. So next I'll tell you about the logistic regression model for interpretation. I'll talk you through the model fitting approach. So I started by performing feature selection using GLMNet, lasso, and stepwise techniques with a 10-fold cross-validation on the training data. And this was to identify stable and predictive features. I compared the variables selected across all the 3 techniques, looking for a robustness in the feature set. And then I primarily leveraged insight from EDA to guide a manual model building process. So I looked for strong trends, which I saw in for example, prior FRAC and FRAC score, and I addressed potential multicollinearity, as you saw in age and FRAC score. I evaluated models based on the log loss error and the area under the ROC curve, and also sensitivity, specificity, PPV, and NPV. To ensure a fair comparison, I adjusted thresholds to fix a PPV of 0.5 for all the models, which allowed for an apples to apples comparison of the remaining metrics. And I selected a final model by looking for a high area under the ROC curve, high sensitivity at the fixed PPV, as well as low VIF values and no evidence of lack of fit. So the predictor variables in the model, variables excluded were site ID and physician ID, as they were metadata. BMI and bone treat were excluded because they're derived from other variables, weight and height, and bone med FU. And age was excluded because it was correlated with FRAC score, and FRAC score had a better performance in the model. So the variables included in the model are prior fracture, FRAC score. These were the key predictors identified through EDA with very strong trends, and also through feature selection. Height, mother's history of fracture, arm assist, rate risk, and bone medications at enrollment and follow-up all showed significant trends with fractures. For example, women with maternal fracture history had a higher proportion of fractures than those whose moms didn't have a history. And weight, pre-meno, and smoke, these didn't have strong or very noticeable trends, but were potential confounders that were good to account for, and also improved overall model performance when included. This is the model. And this is a table of the odds ratio coefficients for each of the variables, the confidence intervals, and the p-values. And so in bold, in bold black, these are the only 2 significant, statistically significant variables at the 0.05 level in the model, mom's fracture history and FRAC score. In white, these variables are not statistically significant, and the other 2, prior FRAC and height, were sort of borderline statistically significant. There's sufficient evidence at the alpha 0.05 level of significance to suggest that for women with a maternal history of hip fracture, the odds of a fracture within 1 year are 137.9% higher than women whose moms did not have a fracture. And that's for women receiving the same medication treatments of the same height, weight, relative age of menopause, personal history of fracture, smoking status, fracture score, use of assistance standing up, and self-assessed risk. There's also sufficient evidence to suggest that for 1 unit increase in FRAC score, the odds of fracture increase by 21.4%, again, for women accounting for those other variables. So these are effects plots that show the predicted probabilities from our model, and it's the proportion of fracture. And so this graph shows that it predicts that the probability of fracture is increased among women whose moms had a history of fracture, and that's the bar on the right. And women whose moms did not have a history of fracture on the left have a lower predicted probability of fracture. And the graph on the right shows the same, but for FRAC score. So with increasing FRAC score, there is an increasing predicted probability of fracture. Among all variables in the model, only 2 were statistically significant, MOM-FRAC and FRAC score. The significance level of those predictors and 2 others, height and prior FRAC, increased when the other variables were excluded. A strong trend in the relationship between prior fracture and fracture highlights its practical significance. Its statistical significance depended on whether the other variables were accounted for in the model. But accounting for those other variables reduced the error rates of the model. And while they may not be statistically significant, they contribute to the overall practical significance of the model in predicting fracture risk. So next, I'm going to tell you about the predictive models. The first is a complex logistic regression model. And I started creating this model by adding some complexity, looking at the trends I saw in the exploratory data analysis. So this is an example of a potential interaction between 2 variables, MOM-FRAC and bone-med. And you can see what I'm looking for here is a difference in trend. So the categories of MOM-FRAC, no in green and yes in orange. These, the proportions of fracture differ between these depending on what category of bone medications you're in. Either you don't take bone medication or you do. And so this is this suggests that I could potentially add an interaction term to improve the model. And then here, it looks like there's a difference in trends between the categories of MOM-FRAC for weight. And what I also saw was that there's a curve, it appears to be a potential curved trend among weight in women whose moms have a history of fracture. And so this indicated to me that I might want to try a polynomial term for weight. So the feature selection strategy for this model was to add interaction terms and a polynomial term based on these trends I saw. The potential interactions observed were among the bone medication variables and that nonlinear relationship with weight. I used the same feature selection process with the GLM-NET, lasso, and stepwise techniques. I performed feature selection after adding either interaction terms or both interaction and polynomial terms. And I focused on the predictors with the high frequency of appearance across all these techniques. I tested candidate models, both created from the feature selection and through a manual iteration process, and used the evaluation metrics area under the ROC curve, log loss, sensitivity, and PPV. And I adjusted thresholds to compare models at a fixed PPV, as I did before. So these are the variables that ended up in the model. Many of them are similar to the variables in the Objective 1 interpretation model. And there's some additional interaction variables included, including with prior fracture, mom's history of fracture, and the bone med variables, among others. Next, I want to talk you through how I chose the threshold. So the criteria for selecting a threshold, the goal was to achieve the highest PPV with a minimum sensitivity of 80%. And having this minimum sensitivity of 80% prioritizes identifying women who will truly have a fracture so that they can get the treatment that they need. And also having a high PPV minimizes overtreatment by maximizing the proportion of fracture classifications that are correct. So these are the metrics resulting from the model. The area under the ROC curve is 0.76. The sensitivity among women who will truly have a fracture, the model correctly classifies 81%. Among women who will not have a fracture, the model correctly classifies 64%. For PPV, among women classified as high risk by the model, 43% of those positive classifications will actually have a fracture. And NPV among women classified as low risk by the model, 91% will not have a fracture. So next, I'll take you through the next model, the discriminant analysis model. I started with predictors from objective 1. I converted the categorical variables into dummy variables. I manually removed some of the variables to reduce the cursive dimensionality that will occur in an LDA model with having unhelpful predictors in the model. It reduces the performance of the model. I did the same thing with adjusting thresholds. I compared candidate models with different predictors in both LDA and QDA settings. The top models were both LDA models. One included smoking status and had a higher area under the ROC curve, and the second did not include smoking status. That was the difference between them, and that had a higher sensitivity in PPV. I also found a model with all of the numerical variables, and it performed nearly as well, which better meets the multivariate normal, the assumptions of multivariate normal predictors in this type of analysis, this type of model, and it potentially will produce more reliable metrics. So in selecting a model, I prioritized the highest sensitivity in PPV, and I did that because smoking alone doesn't seem to trend with fractures. So this is the top model. The area under the ROC curve is 0.75, sensitivity of 0.84, and PPV of 0.44. And then to contrast, this is the model with the numerical predictors only, and this had all of the numerical variables in the data set, not worrying about multicollinearity, because this type of analysis has less problems with this. And as you can see, the area under the ROC curve is just a little bit lower, 0.71, sensitivity 0.81, and PPV 0.4, so similar. The next was the non-parametric model. So I started with all the original variables except site ID, physician ID, BMI, and bone treat. I fit a random forest model using tenfold cross-validation with 100 trees, and I use that to identify variable importance. I selected predictors with at least 10% importance, excluding age, which was highly correlated with a FRAX score. Again, the same threshold adjustment to reach an 80% sensitivity and high PPV. I tested multiple predictor sets, including combinations of the important variables and complexity terms. I tuned M-try hyperparameter, testing 2 to 6 predictors sampled at each split. As I said, I optimized for the minimum 80% sensitivity and maximized PPV. And the final model prioritized simplicity to avoid overfitting, balance sensitivity and PPV performance, and minimize log loss error for reliability. So these are the results from the random forest model. It has the lowest area under the ROC curve of all the models, 0.68. Its sensitivity was 0.81, but its PPV was 0.35, lower than the other models as well. Here is a graph of the ROC curves for all of the 4 candidate models. So in purple is the objective 1 additive model. In green, the complex logistic regression model with the highest area under the ROC curve of 0.76. The LDA model is in red, and the random forest model with the worst performance and it is in blue. And this is a table showing the model comparison with some of the key metrics highlighted in bold. The additive logistic, complex logistic, and the LDA models all perform actually similarly. This graph shows sort of a bias variance trade-off across the models, going from the additive model on the far left to the logistic regression the logistic regression model, the LDA model, and the random forest model on the far right. The dotted line at the top is the area under the ROC curve. The orange line is the validation log loss, and the training log loss is the blue. The additive model performs well with good interpretability. The complex logistic regression model has the highest area under the ROC curve and the lowest validation log loss. The LDA is likely suboptimal due to many categorical predictors, and its metrics may be unreliable because of that. The random forest model has a very low training log loss and potentially could indicate overfitting. The area under the ROC curve is also low, and so I suppose that better tuning may improve performance of this model. So in conclusion, fracture score and maternal history of fracture are statistically and practically significant predictors of fracture risk. Prior fracture history and height are also practically significant. The complex logistic regression model is the best with the highest area under the ROC curve and lowest validation log loss. It's the best choice for prediction. Additive logistic regression offers slightly lower performance but better interpretability. LDA and random forest underperform and are not recommended without further tuning. Prioritizing sensitivity ensures identifying most women at risk while optimizing PPV minimizes unnecessary treatments by ensuring positive classifications are accurate. And the area under the ROC curve and log loss are valuable for comparing model performance across all thresholds, providing a threshold-independent assessment of model quality. This study includes 500 women aged 55 and older across 6 study sites. The data set is likely part of the global longitudinal study of osteoporosis in women, GLOW study, which included over 16,000 women worldwide. It's an observational study, not a randomized experiment, so it can only show associations between features and fracture odds, not causation or changes in fracture probability. It's unclear if participants were randomly selected or they volunteered, which limits the generalizability of the findings. Our results should be interpreted within the context of the sample, women 55 and over at these study sites. But despite these limitations, the study provides valuable insights and a basis for further research. So going forward, the first step would be to validate these models and test them on new independent data to assess their performance, revalidate them at future time points, and if the model performance declines over time, then investigate potential modifications. It would be a good idea to leverage the GLOW study, both for insights into the data and to learn more about other statistical approaches or how to improve these. And then lastly, enhance the random forest model, further optimize the tuning parameters to improve performance. Thank you very much for your time and attention. I'm happy to take any questions. My email address is provided, and I look forward to talking to you. Thank you again.